Okay. Message. All right. So continuing on. So it's going to pass through the pharynx. And after the pharynx, it gets to what? It's a little leaf-like structure that covers up the opening of the trachea.
Epiglottis.
The epiglottis. So the epiglottis is kind of the traffic cop, and that's the way I remembered it. I know I have a cop in my night class, so I'll be careful using this, but just think about the pig epiglottis and what do pigs do, cops? Or one of the things, and don't say beat up. They control traffic, right? All right, I see a couple smiles. That's good. All right, so goes through the epiglottis, down the trachea, and then it divides into the what?
The bronchi.
The bronchi. Then it goes to the
Bronchioles.
the bronchioles. Can you guys hear me okay? It's all broken up.
It's echoing and broken up.
You're breaking up and you sound double.
How about now?
So
You sound the same.
Hello? All right, sounds better?
Yeah.
All right,
Yeah.
so to the bronchioles and then finally to the what?
The alveoli.
Alveoli.
have you?
Alveoli. All right. Now, what happens at the alveoli?
Diffusion?
What was that?
Diffusion?
Okay, so we have the exchange of gases through diffusion. All right. Now, the process, like I said, it's called diffusion, but this is what respiration is the definition of respiration is the exchange of gases. So we have two types of respiration. What are they? All right, so let me rephrase it. So once the oxygen gets into the alveoli through diffusion, we're going to have respiration. And we call that external respiration. So I'll put it up on the chat. So external respiration get on there. So external respiration is the exchange of gases at the alveolar level. Okay. External respiration is the exchange of gases at the alveolar level. Ruben, you're very brave wearing that shirt in front of me. I'm a Dodger fan.
The rivals.
Yep. Worse than the Red Sox and Yankees, I think. So anyway, so external respiration. Respiration is where is the exchange of gases. And external respiration specifically is the exchange of gases at the alveolar level. Whereas internal respiration is the exchange of gases at the cellular level. So the way to think about it, that oxygen is coming in from the outside, so it's external. Whereas at the cellular level, that oxygen is coming from from inside the body. Thus, excuse me, internal respiration. Does it make sense?
Yes.
All right. Now, ventilation, I'll put it on here too. Ventilation is a process of moving air in and out of the body. So it's a little bit different. We think about respiration as doing that, but it's actually exchange of gases. Whereas ventilation is where we move air in and out. So that's why mechanical ventilation means it's a mechanical means of moving that air with a BVM. Positive pressure ventilation, the process of moving air in and out. Okay. All right.
You guys are about to do your writing exercise? Yeah. You need your writing book?
What part of the body controls respiration?
The nose and mouth.
No, they don't control it. Okay, what part of the brain controls respiration?
Parasympathetic?
Well, doesn't the sympathetic do it too?
Yeah.
So what part of the brain would do it?
The
man.
medulla?
What?
The medulla?
Okay, the medulla. The part of the brainstem, right?
Yeah.
So the brainstem is controlling breathing. And remember the chemoreceptors?
Yeah.
So they're sensing how much carbon dioxide and oxygen's in the body. And we know it's carbon dioxide that drives us. Okay. So here's another term for you. Oxygenation. What's oxygenation? Oxygenation is where the blood and the cells are saturated with oxygen. So if we say poor oxygenation, then the patient is not getting enough oxygen. Or if you're the term, let's oxygen, what are we doing?
Giving him oxygen.
We're giving him oxygen. We're trying to saturate that blood and the cells with oxygen. So oxygenate. All right, so I have a respiratory disease, whatever it is. And we'll get more into those when we get to respiratory emergencies. But I have a respiratory disease. So because of that, what's happening to my oxygen level?
It's decreasing, not getting enough.
Okay, my oxygen level is decreasing. Now, what places is it going to be decreased in?
Extremities?
Okay, not necessarily the body parts.
In the blood?
Okay, in the blood. And the blood is one. Where else?
In the brain?
Okay, so the brain's one of those organs that is dependent on that oxygen level. But who really needs that oxygen?
You're breaking up and sound double.
I'm breaking up again.
Yeah,
Low. Dang it.
you sound double.
Hmm. See if it gets better. Nope. I'm just checking out my OG. See how it's coming along. All right, can you guys hear me?
Yeah.
Yes.
Is it better?
Yes.
Yes.
Okay. I'm trying to decide what I want to do. So I'm in two different places. All right. So as we were saying, with me having a respiratory issue, I have low blood or low oxygen in the blood. Where else is my oxygen level going to be low at? Wouldn't you
Wouldn't you have
that
low
oxygen?
oxygen to the brain?
I'm sorry, low oxygen where?
In the brain?
Okay, so that's going to be one of the body parts that is going to be lacking oxygen. But more importantly, what part of the brain?
Cells.
The cells. The cells. Okay. Because remember, that's where the oxygen needs to go along with the sugar to be burned up to be able to create energy. So now we have two terms. If we have low oxygen level in the blood, what all right. It's called hypoxemia because what does the suffix emia mean?
Blood.
Blood. And so hypo is what?
Less than, low.
Yeah, under or below. And then the ox is oxygen. So hypoxemia is low in the blood. Where we have the other term, hypoxia, that means low. Is that echo again? That means low oxygen
Lou,
level
breaking up
at the
again.
cellular level. Let me see. Let me get rid of. Hello? Can you hear me now?
Yeah.
Yeah, you sound better.
Okay. All right. So anyway, so hypoxia is low oxygen levels, hypoxemia, low oxygen level in the blood. Okay. All right. So what can cause to not be able to get enough oxygen down into the alveoli? Carlos, you're frozen. Oh, there you are. So what can cause my body to not get enough oxygen? How about if there's smoke in there, toxic smoke? Off or to put out a lot of fluid. You guys hear me okay?
Yeah, you sound fine.
Okay. Just I don't hear anybody saying anything. See, isn't this great? You could be at home babysitting and taking class instead of being here.
Yeah.
So anyway, what about if remember that ribeye that I've been craving again?
Yeah.
So what about a piece of that ribeye gets stuck in the back of my throat? Or let's say I have an allergic reaction. Then what?
Well, your airway is going to be obstructed. Not going to get enough oxygen.
Exactly. So airway obstruction is going to prevent me from getting enough oxygen. What about Brian, it hit me in the ribs. Am I able to fully expand my chest?
No.
No. What about if I get stabbed or I get shot in the chest? Or what about without my smoking, I develop emphysema? So something can be there to interfere with the amount of oxygen that's going down into my alveoli, which in turn is going to get down to my cells. So if you think about what's happening, and we talked a little bit about it, if I can't get oxygen in, which in turn means I can't get carbon dioxide out, right? So what's the body going to do as a response to that? So better yet, remember normal breathing, right? Can you hear me breathe?
No.
No. Do you see me working to breathe?
No.
So you can't hear me, you can't see me breathe. What else? Am I using energy to breathe? Yeah. Now, if I start working to breathe, you see my accessory muscles going on. You see my nose flare up. You hear me. Is that normal?
No.
No. So think about what we talked about in chapter 8. The body's going to do what it can to take care of itself. So because I'm not getting enough oxygen, that means I'm not getting rid of enough carbon dioxide. So what is my body going to tell my respiratory system to do to help get rid of that carbon dioxide, but in turn get some more oxygen in?
Increase your respiratory rate.
All right, my respiratory rate's going to go up. What else? I gave you two of them. Accessory muscle use and nasal flaring, right? What else is going to happen? Remember the skins? What's going to happen to your skins? Or your skin?
Gonna start turning like purple.
Well, the cyanosis is going to be a late sign, but yes, we're going to have bluing of the skin. But before we get there, what's going to happen to the skin?
Temperature's gonna drop.
Okay, what else? Remember we talked about the precapillary sphincters?
Not really.
Okay, so I'm seeing somebody nodding their head. So those precapillary sphincters are going to close off, preventing any oxygen, any blood from going into those capillaries. Because what is the body trying to do when it shunts off the skin?
Preserve oxygen for vital organs.
There you go. What do we call that process?
Shunting.
Shunting. Good. Very good. So it shunts blood away from unimportant areas, the skin being one of them. And so our skin become pale, cool, and clammy. Or sweaty. Okay. Because it's not getting enough oxygen. That's what the body's going to do. Now, think about this. have you ever been eating something and all of a sudden it got stuck real quick, or maybe even taking a pill and it got stuck in the back of your throat? That ever happened to you? Okay,
Yes.
I see a couple nods. How did you feel? How did you feel when you were choking on that pill, on that piece of meat, whatever it was? How did you feel?
Mm.
You're trying to catch your breath again.
Okay,
Mm.
but what else?
You start coughing.
Okay, you want to start coughing because you want to clear that airway, right?
Mm-hmm.
Did you panic?
Yes. What?
Yeah. Were you like, oh crap, I'm gonna die?
You want to get that out as soon as you can.
Yeah. You got anxious. What do you think happened to your heart rate?
It goes up.
Goes up. So all those are normal reactions of the body to when it's not getting enough oxygen. So think about that. Now, why do we yawn? Other than we're tired or it's too darn early, why do we yawn?
Oxygen.
Yeah, to get more oxygen in. Because before you do that, what's your brain doing? What's your head doing?
Getting sleepy.
Well, you get sleepy, yeah. You start head bobbing, right?
Mm-hmm.
Okay. All right. So I'm that patient. You show up, you see me working to breathe. I'm tripoding. I'm grunting. I got prolonged expiratory expirations. How are you going to take care of me?
By giving the patient more oxygen assisted.
Okay. How? How much?
15 meters.
Okay, how?
Through the nasal.
What?
The mask or the nasal.
What? At 15 liters, you can put a nasal cannula?
Oh no, that's at 6. No more. No
BVM.
BVM, it all depends.
And report tomorrow, okay, so that I can take attendance. And then we're out of here. Ready?
Oh, that's easy. That sucks. I'm just taking attendance and you get out of here. Bam. And they get paid the big bucks. Anyway. Nasal cannula is up to 6. Okay. 6 to 10, you can use a simple mask or partial non-rebreather. Anything above 10, use a non-rebreather. All right. Remember that oxygen is a drug. So whenever you say, I'm going to give the patient oxygen, make sure you tell me the drug, the dose, and the route. So, oh man, my fingers are all messed up. So put them on oxygen, 15 liters via non-rebreather mask, or at 15 liters via non-rebreather mask. So remember those 3 things. All right. So how much did you guys say you're going to put me on?
15.
At 15 liters, how again?
Non-rebreather mask.
Non-rebreather. All right. Somebody said BVM. Okay. For registering for my quizzes and tests, if you have a respiratory rate of 8 or less, or greater than 24, if it asks you how are you going to administer oxygen, the answer is positive pressure ventilation. In other words, you're going to bag them. Okay? You're going to bag them. Oh, sorry. Always look at your patient. I just finished running around the block and my respiratory rate is 28. Are you gonna put are you gonna bag me?
No.
Why?
If it's too low,
No, it's too high.
right?
A respiratory rate of 28 is too high. And remember, 8 or less or greater than 24, you bag them.
Mm.
So you can bag me?
Mm-hmm.
No, because you're not suffering from something that's, like a obstruction or anything. You're just trying to catch your breath.
Yeah, I'm just out of shape now. I can barely run. So yeah, odds are that it is just me being out of shape. So look at your patient. Look at your patient. One of the biggest concerns I get from students as they're finishing up is, oh my gosh, am I going to know how much oxygen to give them or whether to give them oxygen? You know what? That's a very valid concern. The thing is that it all depends. You're going to learn, we're going to teach you how much oxygen the patient needs, if they need anything. Again, if you have somebody out of shape and they just got up and walked down the hall, they're going to be out of breath. All right. Give me one quick sec. Okay, I'm back. All right. So what's anaerobic metabolism?
Without oxygen.
Without
Okay.
oxygen.
And so what does that create?
Carbon dioxide.
Well, remember, all of them, a byproduct is carbon dioxide.
Acid.
Oh, acid.
What kind of acid?
Acid. Acid.
Lactic.
Lactic acid. It creates lactic acid and the body doesn't like that. So we need to make sure we have enough energy production. If not, the cells are going to die. That sodium potassium pump fails and the cell dies. Okay. So I know this is going to be a deep question. So what causes disruptions in the mechanical process of ventilation? So what's going to interfere with my ability to take a breath? Nicole? Oh, never mind.
Choking.
Okay. All right. That's an example. So a disruption of the airway patency. So something is blocking the airway. What else? Some sort of interruption, injury to the nervous system, brainstem specifically. So there are different things that are going to interfere with the blood flow or with the body's ability to get oxygen. The lack of delivery, let's say. Okay. All right. All right. So now let's take a look at the airway. So we get to a patient and they're altered. Doesn't matter if they're confused or they're unconscious. What do we need to do? You guys took CPR. Don't make me rip up your CPR cards.
Got to check for responsiveness of their pulse and their.
All right. But before we check a pulse, what do we have to do?
Check their airway.
How do we do that?
Opening up their the jaw.
All right, there we go. We
That's it.
open up the airway. And there's two methods. So there I am. So you open up my airway. How are you going to do that?
The
Head tilt to left or the I've never seen or heard anybody actually doing the jaw thrust. Or was it the we talked about it last time, but I forgot what it was called. I think it was the jaw thrust, but I've never heard it being used.
Okay. Did they show you how to use how to do the jaw thrust? Did Velvet and O'Sherry show you how to do the jaw thrust? No. You guys are way too quiet. Come on, guys, wake up, cheer up.
Is it when you just flick the jaw open, or I mean, sort of say?
You don't flick it open. It all depends. I mean, when I think of flick, it's just like that. You want to get underneath the jaw back here. Okay, where right in this area here, and you want to lift it up. You see the movement of my jaw?
He's thinking he
I'm just with my finger, I'm lifting away the bone. And then
Okay,
where you
we
can
didn't
kind
go
of,
over
huh?
we didn't go over that then.
Okay. Well, you guys are coming back for skills, so we'll go over it then. But you lift up, and then I do two things actually. I tend to put my thumbs on the maxilla, and then make my fingers as trigger. So I'm lifting up on the bony part. So I'm using my thumbs as anchors, and I'm just lifting up. The other one is you go under here, and then where your thumbs down over here, and just. And most students like that method better than my method, which is pressing down on the maxilla. Whatever works for you. Okay. Now, when are we going to do the jaw thrust maneuver?
Only when the head tilt chin lift doesn't work, or
And there's a spinal injury.
When what injury?
Injury.
Oh, sorry, you broke up.
And there's a spinal injury.
There you go. Awesome. Spinal injury. Any suspected spinal injury, you do not. I'm sorry. Whenever you have a suspected spine injury, you use the jaw thrust maneuver because you're not moving the neck. Whereas in the, what's the other one called?
the head tilt chin lift.
There you go. Head tilt chin lift is going to lift the
What's the
jaw,
tilt?
thereby moving the spine. What was that?
No, it's going to move the head, which then moves the neck, moves the spine, moves. It's the mechanism of what it moves. So yeah, that makes sense.
Yep. So, so yeah, any type of suspected spinal injury, we use the jaw thrust. Otherwise, we do the head tilt chin lift. All right, good. So we get to the patient. Doesn't matter what kind of patient. I mean, as far as the chief complaint, but you get to them. I remember earlier. All right. And we open up the airway, but we hear a sound. This is without listening to the lungs. What are those sounds?
A gurgling sound.
Okay, gurgling. Gurgling represents what?
There's like fluid.
There you go. Fluid in the lungs. I'm sorry, not in the lungs, in the back of the throat. Okay. Gurgling in the throat. Fluid in the throat. All right. Where people get confused, and trust me, you'll see this in the future. And the other noise is snoring. And people think, oh, I need a suction when they're snoring. No, you don't. What is snoring?
It's like the vibration like that.
Okay. Basically, muscle relaxes and causes an obstruction where the air is trying to go through. So that is snoring. So usually, like the tongue falls back, or maybe around where the uvula is, there's extra tissue, and it's causing an obstruction, which causes snoring. So, everybody, for your significant others, if they snore, don't smack them in the nads. Don't twist anything. Don't suffocate them. Don't throw a shoe at them. Okay? Poor people. And I don't care if it's male or female, because females snore too. I don't think you ladies are going to fess up to it, though, are you? All you need to do if somebody is snoring is reposition the airway. Or the other thing you could do too is drop an MPA.
What's that?
They didn't go over the MPA?
Refresh my memory.
Yeah. OPAs and MPA.
Yeah. The MPA is the nasal pharyngeal airway. That long tube that you put lube on and you stick it up the nose. And that's because it ends up in the nasal pharynx. So therefore it's called the nasal pharyngeal airway. Okay. So yeah, all you need to do is reposition the airway, and if you want to ensure a patent airway, when we use the word patent, P-A-T-E-N-T, we really mean it's open. But they decided to go with a fancy word and say the airway is patent. It's open. All right, so we got snoring, we got gurgling. What else?
Crowing.
Wheezing.
Crowing. Sounds just like a crow. There's some sort of constriction there. It's caused by a spasm as air is trying to get through. All right. So we got snoring, gurgling, snoring, gurgling, crowing, and what's the last one? Strider. What does strider represent?
High pitched sound during inspiration.
Okay, and why is that occurring?
The upper airway is obstructed from swelling.
Okay, how much is it obstructed?
Significantly, if it's making the high pitched noise, it's kind of like, I guess I would assume it's the same as kind of like when you're whistling. I mean, to make your lips to be able to do a high pitch, like little airway noise, it would, I'm assuming it's the same thing, but within your upper chest area or your upper airway.
Uh-huh. Yep. Yeah, and remember these forced noises are in the upper airway, so around the throat. You're not going to get those down in the lungs. And again, remember that for the future because students tend to mix that up. Strider, crowing, gurgling, snoring, all those are upper airway noises. Okay? All those are upper airway noises. All right. Let's take a quick break. Say about 5 minutes. Okay? All right. I'll see you in a few minutes.
Right.
Welcome back. Sorry. All right. So now. Something. All righty. So. All right. So as far as suctioning, where do they teach you about suctioning?
Suction on the way out.
Okay. So you want to suction on the way out. Sorry?
Use suction for 10 to 15 seconds.
Okay. What's a little shortcut you could use to suction? Or as far as that time? They say hold your breath. And when you need a breath, it's probably a good indication your patient does also. How about for kids? How long do you suction kids for?
You okay?
Five seconds. All right. Now, how do I know how far I'm going to go in?
Measure from your pretty much the jawline from your ear to the corner of the opening of your mouth.
Yep. Corner of the mouth, tip of the ear. Okay. How about if the patient has a stoma? An opening here in the throat.
You suction it from there.
Okay. So yeah, you're gonna measure from that opening to the carina. Okay. All right. So you've measured and you insert it. You create the suction as you start to withdraw. Again, no more than 10 to 15 seconds, or hold your breath. And when you need a breath, it's a good indication they need a breath. All right. Remember to oxygenate your patient before and after. And usually you want to suction 2 times before you oxygenate again. Because remember, not only are you sucking out what's in there, you're also sucking something else that's in there. Air. Or as somebody got pissed off at me because I didn't say it creates hypoxia. Well, no shit. But I'm trying to simplify it. You suction out air too. So, all right. Now, I'm right. Oh, did you see me? Wait, hold on. And I'm still. So what are you gonna do? You've already opened up my airway.
You give chest compressions.
No, you gotta check for pulse first.
Oh yeah.
For that. You want to make sure that airway stays open. And how do you do that?
OPA.
Or
NPA.
or MPA. All right. So how do you measure an MPA?
Tip of the ear to the tip of the mouth.
All right, corner of the mouth, tip of the ear. No, an MPA is from the tip of the nose, tip of the ear. I have my little sayings, and this helps me remember, so that's why I share them with you guys. Tip of the nose, tip of the ear. Okay. And then how do you insert it?
Lube.
What was that?
With lube. You lube it up and then you put it.
Okay, so you lube it up. If you don't have KY, what can you use?
If you don't want, sorry, broke up.
If you don't have KY, what can you use?
I want to say the person's own saliva, but I don't know. Oh, okay.
Can you use yours?
No.
Only if you don't like them. Yeah. Use the person's own saliva. All right. So I've lubed it up. And then what?
The bevel, the tip of the bevel facing up, correct?
It's not the tip. The bevel's the
bevel.
angled side where the opening is. All right. So bevel to the septum. And which nostril are you going to use?
It's the right one, right?
Why the right one?
Turn your camera back on.
Why are you going to use the right one?
I'm not sure.
Because it's the larger of the two nostrils. Use the larger of the two nostrils. Usually it's the right. You insert it with a bevel to the septum, center of the nose. All right. What if you meet resistance?
Try the other nostril.
Well, before you do that,
You slightly twist it.
yep, twist it. And if you continue to meet resistance, then you take it out and you use the other nostril. All right. And what's the other adjunct we could use?
OPA.
An OPA. And how do we measure that?
The tip of the mouth to the tip of the
Not
ear.
the tip,
Oh, the
corner of the mouth.
corner of the mouth.
Corner of the mouth to the tip of the ear. Or there's another way. What's that other way?
I'm not sure.
From the top of the mouth to the angle of the jaw. The angle is as you see the jaw comes here and then it turns. So this bony part right here, this pointy part, that's the angle of the jaw. So you're going to measure it from the top of the mouth to the angle of the jaw. Same thing. All right. And then what?
Make a 180 turn on it.
No, before you do that,
Or you insert it in the airway.
I'm sorry, what was that?
Insert it in the mouth for the airway.
Okay, how?
Like placing it in the middle and then turning it 180.
Okay, but how are you going to place it? Tip to the top. Tip to the top. So you go in halfway, then you rotate it 180 and let it fall. Or let it come down flush against the lips. So that's the important thing, tip to the top. What about if you have a pediatric patient? Somebody say, I don't know.
I don't know.
Okay.
I don't know.
What you do is you get a tongue depressor and you press the tongue and you just insert it. So here's the hook. So you just go straight down. Because what it does with the curvature, it gets behind the tongue and it moves it out of the way. Plus, some of them have channels on the sides and another one has it right down the middle. And so the oxygen is able to go down that channel and it's keeping the tongue out of the way. Because what is the most common cause of an airway obstruction?
The tongue.
The tongue. Yep, the tongue. So, with that said, we have a kid and we know their head is bigger than their body in proportion to an adult, right? So if you lay them down flat, and you guys took CPR, so you know this, if you lay them down flat, what happens to their head?
Their airway becomes still obstructed.
Okay. What did you say, Jessica?
Their head goes forward, like in the chest.
Okay. And so it obstructs the airway. So what can we do to minimize that and keep the airway open?
Like placing like a pad, something under
Underwear.
like.
What'd you say, Jessica? I couldn't hear you.
Their shoulders.
Okay. Yeah. Use a folded sheet or towel underneath the shoulders. That way it brings the shoulders up and it brings the head back into alignment. It puts them what we call the sniffing position. Okay. Puts them in the sniffing position. All right. Good. All right. So Brandon and I, we go out drinking tonight. And Brandon has a few too many. Now his wife is out. His wife is busy, so she's not gonna know. Okay, just don't show her the video, Brandon. And Marshall, they can't hear me through my door. So anyway, so I get him home, and as soon as he walks in, he passes out. Because he had 3 4 horsemen. Not one, not two, but 3. Like, Damn, I could only handle 2. Damn. Anyway, so do I leave him there without doing anything?
Nope.
Why?
If he throws up, he might aspirate.
Okay, he might throw up and aspirate. Besides aspirating, what else? Aspirating means he swallows vomitus into the lungs. But what else along those lines?
His breathing or his respiration. Like
It's his breathing and respiration. Now, right now, if we get anything in the back of our throat, what do?
swallow it.
What do you think? Let's,
He'll swallow it.
or
Breathe it.
Cough. Cough it out.
not breathe it out.
Cough it out.
We cough it out. We cough it out. All right, so I'm here, I promise. So if he is drunk, which I know he isn't, but if he is drunk, is he going to be able to cough when he gets vomit in the back of his throat?
No.
Nope.
No. So besides aspirating that vomit, what else can happen?
You choke on it? Swallow
Chokes
it?
on it. Now remember, he doesn't have the ability to swallow or cough right now. It's just the vomit that's back there. But we don't have our MPAs or OPAs. So what do?
Turn him on his side.
Okay. What do we call that position?
Lateral.
Lateral what?
Lateral recumbent position.
There you go. The lateral recumbent position. That's going to keep the tongue out of the way, and it's going to help with drainage. So now you know, next time when your friends gets really drunk and they pass out, just put them in the recovery position. Of course, you need to paint all that stuff on their face with a Sharpie and everything, but we'd never do that, would we? All right. So what kind of suction devices are there?
Portable suction devices.
Okay, where do you use portable suction?
That's probably what we use in the field. Like if we went into somebody's house or something, we would take a portable suction device.
There you go. Yeah, you'll use portable, and that's what you take inside the house with you. Now that portable could be handheld, or it could be battery powered. The handheld, they can be pretty good. Some of them have bigger diameter openings, and so they can suction out bigger chunks. Whereas the smaller ones, like the battery powered, they have smaller tubes, so it's not as good. All right. What other kind is there?
Mounted suction.
Yeah. And where do you find that?
Hospitals.
What was that?
And the hospitals?
Okay, you find in the hospitals and where else?
Ambulance.
Ambulance.
Inside the ambulance. Yep. Those are mounted to the ambulance. So you can't just pull it out and take it inside with you. So part of your inspection in the morning is making sure your suction works.
I done, teacher. I done.
All
Teacher.
right. So we use either battery powered, portable, wall mounted.
I done.
We have the suction tubing, and then we could use one of two types of catheters. What are those catheters called?
The rigid catheter.
Okay, the rigid catheter. That's hard plastic. You guys got to play with that. What's another name for that rigid catheter?
Hard
A
catheter.
heart.
What'd you say, Jessica?
Hard catheter.
Okay, a hard catheter, a rigid catheter, but there's another name for it. Starts with a Y.
Young.
Yanker.
Yeah, the Yankauer.
Yank out.
All right, what's the other type of catheter?
The soft catheter.
Okay, soft catheter, also known as the
French catheter.
French.
the what?
French.
French catheter.
Yep, the French tip catheter, or what's another name for it?
Hmm.
Not sure.
Soft catheter, French tip catheter, and flexible catheter.
I,
All right. Uh.
Am I?
You're in the ambulance, and you need to put a patient on the lateral recumbent position. Which lateral recumbent position are you going to put him in?
On the right.
Left side.
Okay, I heard right and left. So which one is it?
It's the left side, isn't it?
Okay, why?
Easy access.
What do you mean access?
The way the bench is positioned inside the ambulance.
Yep. Well, yeah, the way that the bench seat is set up, for them to face you, you need to put them in the left lateral recumbent position, so they're facing you. Okay. All right. So you guys remember minute volume?
Yeah.
Yes.
Okay.
That's right.
So what is minute volume then?
Minute volume is tidal volume times frequency.
Times respiratory rate.
Yeah.
And what's the average tidal volume?
500.
Yep, 500. All right, good. All right, now you guys are waking up. How much dead space is there out of that 500? How much goes into the dead space? 150. It's not that bad, Miss Jessica. It'll get better. Dead space is 150. So out of 500, 150 is dead space. So we only have 350 left. So very, very, very important. All right. So now, so earlier we talked about something. Oh, about the upper airway noises. Now we have lower respiratory noises. This is coming from the lungs. Okay. So I'm gonna shut up and I'm gonna include audio and I'm gonna use these lung sounds. These lung sounds. All right, can you hear me?
Yeah.
Is it echoing?
Yeah.
No. No.
Professor Peratoni, Professor Peratoni.
Is it echoing?
No.
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 For me, it's echoing.
All right, hold on. Better? Better?
No, it's doubling up on the
It's
voice.
doubling up on the voice.
How about now?
Yeah.
Better? Okay. All right, let's hear one. So normal, you'll hear the swish in and out.
Please register to listen to these lung sounds. Please register to listen to these lung sounds. Please register to listen to these lung sounds. Please register to listen to.
Oh, hell no.
They charge for everything. They charge for everything.
Yeah, I've done this before. I didn't really notice anything different. It's horrible.
I do. I need some idea of the threat we face.
We're trying to prevent.
Hey everyone, welcome to our video on lung sounds. This is a collection of lung sounds that we have in the library at our website, emtprep.com. We are excited to offer these to you, and we hope you enjoy.
So do you hear the normal airflow of inhalation and exhalation?
Yeah.
Now, it's really amplified, so you have all that, but there's nothing in there. So normal airflow. So this one, when we talk about crackles, think about being a little kid and you had a glass of lemonade and you had a straw in there, and of course all kids, what do you do with a straw and fluid in a cup?
Blow bubbles. Blow bubbles.
You blow bubbles, right? So think about crackles as exactly that. It's fluid in the lungs, and it's representing by the crackles, the popping sound or the bubbling sound. So listen to it. Remember the previous one. Now listen to the crackles. Hear that bubbling? So these are fine crackles. They're lower, and you can really hear that bubbling sound, where the other ones were kind of rough. Do you hear how short that expiratory phase is? It doesn't get all that air in, and then listen to that expiratory part of it. You'll notice it's very short. And even the inspiration is short. Did you notice the difference with that diminished lung sound? It wasn't as full as the normal ones were. You guys doing good so far?
Yeah.
All right. Now wheezes, I think we've talked about it before. Wheezes is where you have bronchoconstriction and you have mucus buildup. And so air is going through that narrowed opening, creating kind of a high-pitched whistling sound. This is usually indicative of something like asthma. And the reason it's in exhalation and expiration is because we're trying to get rid of that extra carbon dioxide in the body. So we tend to have a longer expiratory phase or longer breathing out to help get rid of that extra carbon dioxide. So let's listen to this one. And did you know the prolonged expiration? You notice that?
Yes. Yes.
don't worry so much about this one. This is when there's a disease called pleurisy, which is inflammation of the pleural sac that surrounds the heart. And so the lung is rubbing against it, and you hear that rub. And there should be an H in front of rhonchi. But rhonchi is also a popping sound, and this is usually indicative of pneumonia or bronchitis because there's junk in there. It's not necessarily fluid, it's just kind of like phlegm way down deep inside. So it's popping as the patient breathes. Okay. Stridor is not a lower airway, it's an upper airway. So, any questions?
No.
All right. You guys are easy. So remember the ABCs. So with airway, we open up the airway and we assess breathing. So we already opened up the airway, right? Head tilt, chin lift, or modified jaw thrust. We ensured we had an open airway by using an airway adjunct. And now we move on to breathing. We want to check the rate, the rhythm, and the quality of breathing. So how do you get the rate?
Visual,
What was that?
like visual, watching for the chest to, like counting the respiration.
All right, there you go. Real simple. The rate is the number of respirations. What about the rhythm?
To make sure there's like a pattern that's consistent.
Exactly. It should be a normal, regular in and out, in and out. Nice, steady rhythm. We don't want some funky rhythm. Okay, we don't want norteñas. All right. And then the quality. How are we checking the quality? Brian, wake up.
Make sure that the quality is good. It's nice. What is it?
It's what we call full and effective.
Good expansions.
Yeah, we want full expansion of the chest, full and effective. Full deep breath, and we get enough air in and enough air out. All right. What if they? Nah, that's old CPR stuff. Look, listen, feel. You look for breathing. You listen for breathing in your ear, and you feel for breath on your cheek. Real simple. Now, the other assessment, as you just heard, was the lung sounds. Anytime you have a patient that has shortness of breath, listen to their lungs. Listen to their lungs so you know if something is in there, if the respirations are normal or abnormal. If you have wheezes, usually indicative of asthma, and they had a history of asthma. So now what? They're probably having an asthma attack. So we can go down the line. How much difficulty in breathing are they going to have?
A lot. It's gonna be difficult.
Yeah. All right. So I was going to ask you how you would treat that, but we're not there yet. All right. So we talked about inadequate breathing. We know that the body's not going to be able to get enough oxygen to meet its needs. So the body's going to start adapting, try to take care of itself in that case. All right. So you show up to your patient, whatever the cause, traumatic injury, natural cause, maybe they have some sort of medical condition, whatever it is. And again, you've seen the CPR video. And so you have the patient laying back. What kind of breathing is that?
Agonal breathing.
Agonal. All right. So we have agonal breathing. What does that mean?
Big gas.
They're gasping breaths. Why is a patient in agonal breathing?
Because they're under cardiac arrest.
Okay. They're probably in cardiac arrest or going into cardiac arrest. But what does it indicate other than cardiac arrest? What it indicates, the way that I learned agonal, and it makes perfect sense. Agonal is kind of dying out. Have any of you ever run out of gas in your car?
Yeah.
I have. Right before I ran out, what did your car do?
Started failing. Started stopping him.
It started sputtering, right?
Yeah.
Well, think about the body running out of gas right before death, right? It's the last little spurts that it has left, just like that engine, right before it dies out. Put, 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 put. And you even seen it in the movies when they run out of gas, right?
Yes.
Some of you don't watch movies.
I've seen it.
Yeah. So just think about that, dying out. It's sputtering out. It's just about dead. So that's the way to think about agonal. So not only do you have that with breathing, but also the heart can go agonal. Just a couple little spurts of electricity from the ventricles, just as it's dying out. Or think about a rabbit that just got shot and it's twitching its little leg.
All right.
It's twitching its little leg right before it dies. Same thing. All right. Anyway, nice bunnies. All right. So just remember normal and use the opposite for the abnormal. We've talked about normal breathing, right? It's effortless. It's quiet. We don't have to think about it. We don't have to work at it. It just happens naturally. The abnormal part of it is when we're working hard, where we kind of have to think about it, where it's noisy, where there's no noises in the lungs. And talk about sticking your nose where it don't belong, right? Sticking into the lungs. Oh, come on, guys, wake up. Or are my jokes that corny? So let me ask you a question. And this is a serious question. So you have a patient and they're not breathing. How do you want to deliver oxygen to them?
BVM.
Okay. Why a BVM?
Because you need to make that pressurized system in their lungs.
Okay. Would you put them on a non-rebreather?
Yes.
If they're not breathing, you would put them on a non-rebreather.
I guess no.
Okay, so let's talk about why not.
Because you don't want to do any damage to the lungs or anything. Because
No, not necessarily.
If they're not breathing, they won't inhale the oxygen that's coming from the non-rebreather.
Exactly. And was it you, Dylan, that said about the BVM?
Yeah.
Okay. So you talked about that pressure. If the person's not breathing and you put that mask on their face, we got oxygen coming to that mask, right? But is it getting inside the body?
No.
No. Because there's no negative pressure being created. So that oxygen is kind of going to waste because there is no negative pressure being created. Okay. So there was an instance, this is why I bring it up. There was an instance where fire department went on a call for a baby not breathing. And guess what they did? They put that baby on a non-rebreather. Do you think that baby lived?
No.
Nope. All right. So again, don't be so worried about how am I going to deliver oxygen. Look at the situation. Okay, look at the situation. Because if they really need oxygen, what are you going to do? What are you going to do? Simple answer.
Give them oxygen.
You give them oxygen. As far as BVM, look at the respiratory rate and look at the respiratory effort. In questions, and I'm trying to remember if you guys have had it. On questions, you want to look to see if they're able to oxygenate. If the patient is cyanotic, if the patient is really tachypnic, rapid respiratory rate, they're blue. If they are hypoxic, or they have hypoxemia, I should say, because the pulse ox is going to measure the amount of oxygen in the bloodstream. Here's a pulse ox. So you put it on the patient. You put it on the patient. Of course, I'm a stubborn patient. What do you see? The top is my pulse rate. The bottom is my pulse ox. How much oxygen do I have in my body?
99.
99%. So I'm doing pretty good, huh?
Yeah.
Okay. But what about if that pulse ox is 89? Is there an issue?
Yeah.
Yeah. So what do you think I'm going to do? As the ENT, what am I going to do for my patient?
Put them on
Give
oxygen.
them oxygen.
I'm going to give them oxygen. Yeah. So you look at your patient. There are some conditions that we'll talk about in the future that can get some oxygen, but we're not going to give them a lot of oxygen. But a respiratory patient, they need it. We will give it to them. But whether it's a cannula, a mask, or a BVM, it's going to depend on the presentation and the condition. So don't sweat don't sweat remembering, oh my gosh, what am I going to give them? How am I going to give it to them? Okay. We'll get you ready for all that. All right. What's the preferred method of delivering oxygen to a patient?
Cannula? Nope.
Concentration is not high enough because it blends in with the ambient oxygen.
The non-rebreather mask.
Okay. Because it delivers close to 100%. But what about if we have to breathe for the patient? What's the preferred method? BVM connected to O2. Goes again. Okay. So BVM connected to oxygen. How many people?
Is it just one?
Here's a problem with one person BVM. C-clap or CE, ventilate. Can I close off the entire mask? Can I guarantee a full seal?
No.
Mm-mm. So, there's tricks to try to keep or maintain that seal, but what's a better way to maintain that seal?
By one person sealing the whole cup and the other one giving the breath.
So two-person BVM. Exactly like you said, one is maintaining the seal, the other one's bagging. Next best method is one-person pocket mask. And then the least preferred is one-person BVM. Even though you're delivering 100% oxygen, you just can't guarantee a full seal. Okay. Just so you know about it, they have what they call flow restriction oxygen power device. Flow restricted oxygen power device. FROPD. We also know it as a demand valve. It's out there, just so you know. You can tell because of the long green hose that attaches to the regulator. And you push a trigger or squeeze a trigger, and it delivers air. It has an alarm where you stop. Otherwise, you'll overinflate the lungs and you can pop that lung, especially with kids. Okay. But other than that, it's there. We don't use it anymore. Some places still have it for whatever reason. Most places gotten rid of them. They're good for like smoke inhalation patients, but that's about it. Okay. You guys learn about mouth to mouth? Do we do mouth to mouth?
No.
Okay. What about mouth to nose? Who do we do them on?
Kids.
Infants.
Infants.
Infants. And you guys learn mouth to mask and CPR. So any questions on mouth to mask ventilation? Okay. You guys have any questions on BVM?
No.
Nope.
You know that the BVM can be used with a lot of different things without putting any type of adapter on it. The end that hooks up to the mask, it's a 1522 millimeter connector. So it will either fit inside or it will fit inside. So here's a connector. It will either fit right over it or it can go
Over it.
inside. One of the two. Okay. Before, if you had a patient that was on a vent, you had to have somebody that was either going to be bagging the patient the entire way, and it still happens. Don't get me wrong, still happens. Or you had to have a respiratory therapist that could do that, or they took a ventilator. Well, nowadays, it's a lot easier. They have what they call ATVs, automatic transport ventilator. Okay. And what that is, it's a small little device, and you have the picture in your book. Put the settings, attach it to your onboard O2, and let it start. And it's going to transport, or it's going to ventilate the patient on its own. Now, you're in an area like I used to be. And so you work in cardiac arrest. The fire department for us was non-existent. They had one, but usually they were a little bit too drunk to go on calls, and they never went on medical calls. So if I had a cardiac arrest, guess what? Either A, I just get permission to call them, or B, I had to have to get pretty good at doing one-person CPR. And as a paramedic, I got other things to do for the patients besides just doing compressions and bagging the patient. I need to get an IV, I need to give drugs, I need to think about what else is going on. And so we could put a patient, we got compressions going on, right? Well, if I hook up the patient to this automatic ventilator, guess what? I don't have to worry about airway. The machine's going to do it for me. Or I'm sorry, not airway, breathing. The machine's going to do it for me. So they're pretty good in that respect. And the one they have out where I used to work, that was both a ventilator and a CPAP. So it was a 2-for-1 deal. Thought that was kind of cool. So, all right. Any questions on the ventilators? Either this is making perfect sense or nobody wants to say anything.
I think we're good.
This is how you guys are going to be on your next exam. I need to take a picture of this and put it as my screen saver in my background. So every time I look at them, I'm like, yep, that's my morning class. Can't see him. Get out there. Mm, mm, mm. So the other thing that we do nowadays is CPAP. I'd ask you if you have any questions, but I already know the answer to that. So I'm going to ask you, what is CPAP?
Continuous
CPAP.
positive airway pressure.
All right, continuous positive airway pressure. What does that mean?
Like a steady flow of oxygen being delivered, like continuous oxygen being delivered.
Okay. And so what is that doing to the body?
Helping it breathe.
Okay. Because you have continuous positive airway pressure coming in into that negative pressure. It's forcing that air in. And the CPAP machines are just like the BiPAP or the sleep apnea machines. Anybody, and this is a rhetorical question, so I don't expect an answer because it could be an embarrassing issue. But anybody use those machines at night? Attach it to their face when they go to sleep because they have sleep apnea?
Where I used to work, they used to use it.
My dad had to be on it. He hated it.
Yeah, I'm supposed to use one, but I tried it a couple times and I can't do it, man.
All I'm going to tell you is one thing, Brandon. Reggie White. He suffered from sleep apnea. Remember Reggie White?
Yeah. The football player?
What was that?
The football player?
Yeah, the football player for the Eagles and the Green Bay Packers.
Yeah.
Yep. He had sleep apnea and he died as a result of it. So CPAP does help because it's pushing air constantly. Now, why we use it is not because people are snoring or they have sleep apnea. They use it, and we use it in EMS to help keep the airway open, more so to push air into the alveoli. If they have asthma, if they have CHF, it could be used to push that air in. Because the body can't do it for itself right now. It literally, I kid you not, it literally pushes the fluid out of the lungs, out of the alveoli. So that way the oxygen can get in there. Because remember what we said about oxygen and water, right? Oh, you're seeing me use my type pen. Sorry. So oxygen cannot diffuse through water, through fluid. And so by using CPAP, we're actually pushing some of that fluid out of the alveoli and into the bloodstream. All right. Can we use CPAP on a person that's unresponsive?
Yes.
They have to be awake. I mean, they could be a little bit out of it, but they have to be awake. They can't be apneic. They have to be able to breathe on their own. Okay. What else?
Is there a age limit?
Is there what?
Age limit, like for children?
No.
No.
Especially for asthma. Do this. You guys ready for a break?
Yep.
Yep.
So let's take a break while I look some stuff up. And what do you want? 10 minutes, 15 minutes?
15 should suffice.
15. So at 10:40?
All right.
All right. I will see you then.